Hello and welcome everyone. Thanks for joining us for today's webinar on Bridging the Gap, Disparities in Heart Failure Associated with Type 2 Diabetes, an opportunity to improve care in the African American community. This webinar is presented by ADCES in association with AstraZeneca U.S. Medical Affairs, Cardiovascular and Metabolic Diseases Division. This webinar is educational in nature and contains no promotional or product information. There is no continuing education credit for this webinar, and handouts are not being distributed. If you would like to ask a question during the presentation, please feel free to type your question into the Q&A box on your screen, and we'll answer as many questions as we can during the Q&A session at the end. So I would like to introduce our presenters today. Prasamar Annunciato is a Senior Medical Science Liaison at AstraZeneca. She's been involved in the diabetes and cardiovascular areas for over 20 years, serving as hospital cardiovascular disease educator, diabetes program coordinator, and nurse practitioner in hospital, long-term care, and outpatient settings. She's also been a textbook chapter author, pharma and congress speaker, consultant, and advisory board member for various pharma and medical software industries. Chris moved into the pharma industry in 2017. Shamira Robinson is a registered dietitian nutritionist with a background in public health and diabetes education. Her work focuses on eliminating disparities, promoting health equity, and uplifting marginalized communities through nutrition. Shamira currently serves as a nutrition consultant with the Culture of Wellness, where she helps organizations develop inclusive resources and equitable strategies required to address the nutrition needs and health concerns of diverse groups. So it's our honor to have them both here with us today, and without further ado, I will turn it over to Chris to get us started.
Thank you very much for that very kind introduction. It is truly my pleasure and honor to join all of you today, and I have had the pleasure of working with Shamira in the last few weeks, and I'm really pleased to work with her and know her passion as well. On behalf of AstraZeneca, we want to thank you all for this opportunity to talk to you about bridging the gap in disparities in heart failure that is associated with diabetes. So without further ado, let's get started. So the goals for today really is of this presentation is to tackle the disparities as well as the challenges that exist in the African American communities that they face by identifying key areas that we as AstraZeneca and the healthcare community can actually bring about change. And some of the goals that we have today are to review the disparities and explore the causes of disparities among African American patients, to also look at the health disparities in cardiovascular diseases, including hypertension, heart failure, and CKD among the African American population. And then lastly, to take a look at what we can do to look into the unmet needs and raise awareness for patients as well as healthcare providers of African heritage regarding the effects of cardiovascular disease within the community. And maybe together we can work to address racial as well as ethnic disparities. So let's take a look at why do health disparities exist and what these social determinants of health and how it can influence health outcomes. If you look on the slide on the right-hand side, you can see the different factors that affect health disparities. You have economic stability, the neighborhood and physical environment, healthcare systems that exist within the community itself and the social context that exists, food availability and preferences, as well as level of education. We do know that minority groups often lack access to healthcare services because of the housing areas that they may live in, as well as the income level. And people who are adults who are most likely working may seek help later and delay that treatment instead of going to the doctor right away. And there's also inability to actually afford insurance in this group. People who are a minority are 1.5 to 1.8 times more likely to live in poverty, and a lot of them 2 to about 3 times more likely to not have any insurance. Shamira, do you have any input on this section?
Yes, thank you, Chris, and it has been a pleasure to collaborate with you as well. And I think it's important to note that we can't have the conversation around health disparities without talking about structural racism. Now, I want everyone to pause and breathe. And I know that the word racism can be very charged, but we're not talking about on a personal level, where character or moral compass. We are talking about the systems that are in place. And I'll go ahead and define that for us. And I'll use the definition commonly used by Dr. Kamara Jones, but structural racism really focuses on the systems of power that structure opportunities based on how we look as people, right? And so that means when it comes to things like housing, education, and jobs, structural racism unfairly disadvantages certain groups while also offering unfair advantages to other groups. And I think a great example of this is redlining. So for anyone who is not familiar with redlining, following the Great Depression, the federal government created these maps that color-coded neighborhoods by creditworthiness. And so African American neighborhoods were considered higher risk, so they were coded red or redlined. And so with private lenders seeing this, they were less likely to offer loans and things for those areas, which meant less investment. So in those largely Black communities, there were fewer resources. There were fewer businesses, which means less opportunity for employment, fewer grocery stores, which means less opportunity for access to fresh food, fewer hospitals, which means lower access to care, and also fewer green spaces. So when we're thinking about being able to get out and have safe activity and being able to exercise in that way, options are really limited. And so all of those factors, that happen at the policy level, that happen at the federal level. And so as we're going through talking about health equity and health disparities, keeping in mind structural racism and how that plays into the social determinants of health that still impact the people that we see today.
Thank you, Shamira, for providing us that important context. Now, looking at understanding the social determinants of health, this is a very complex situation wherein it's also very interrelated with the individual, the provider itself, the health system available in the community, societal as well as environmental factors that can contribute to the disparities in health and healthcare. So if you look on the right-hand side here where there's the social determinants of health, it really covers across the board the community and the social context, the economic stability, the education, food, where you have certain areas where there's food deserts, the health systems and the quality of those health systems that are available in those areas, as well as the neighborhood and physical environment that exists. All of these things can contribute to health outcomes, and that is the mortality, the morbidity, the life expectancy, healthcare expenditures, health status, as well as functional limitations. And in the broader context, what causes health disparities are really multifaceted. So in a broader sense, you see the social political environment that Shamira had mentioned, but also you're looking at the community norms as well as lifestyles, and again, the federal, the state, and private financing organizations that are available for those communities, the physical and social environment that we live in, and the community differences in healthcare availability. All of these things play into the overall health outcomes and disparities. And looking at the reasons for disparities, it's really multifactorial as well. There's the provider-related disparity wherein there may be bias within providers. There's clinical uncertainty on how to manage patients. There's also certain beliefs and stereotypes about behavior or health of minority patients. And then there's also the patient-related aspect of this. Their preferences in seeing providers and what their beliefs are, and treatment refusal, or care-seeking behaviors and attitudes that may impact their overall health, as well as clinical appropriateness of care. And in terms of health systems related, it really has to do with geography, availability of healthcare institutions, and the quality of healthcare that is provided for communities. There's healthcare access and delivery of healthcare services that may vary from neighborhoods to neighborhood, the lack of interpretation as well as translation services, as well as time pressures that are placed on physicians to see more patients every day. Shamira, please provide us additional context on this.
For sure. So yes, so many different factors that go into health disparities, but things that we can focus on specifically as diabetes care and education specialists, I want to hone in on bias and stereotypes. So when we mention those things, it's really the use of social categories such as race in acquiring information, processing information, and being able to recall that information about other people quickly. And it's easy to refer to it as like a cognitive shortcut. It can be a positive shortcut or a negative shortcut, but things that we do to make those associations, especially under pressure. Now, while this can be, positive or negative, there are real implications from these stereotypes or this bias when it does show up. And for example, as recently as 2017, there were still medical textbooks that had quotes like, "Blacks often report higher pain intensity than other cultures." So imagine, these are what our healthcare professionals in training are being told and being taught. And so when it comes to those moments where you have to make that quick decision, that quick diagnosis, offer that quick method of treatment, those are the things that are easy to pull from when we're discussing provider bias. And so as we move forward in thinking about how we can be more equitable in our practice, it's important to accept that it's there, it's real. We all have these shortcuts that we do and these associations that we make, but thinking about how we can shift from using some of those cognitive shortcuts or really be aware of that provider bias and really start incorporating more person-centered care. And that's in our interactions with the people that we serve. That's when we're thinking about hiring and promotion practices and all across the board.
Thank you, Shamira. Now, looking into which populations really face healthcare disparities, it really comes across socioeconomic status, age, geography, the language, gender, disability status, the citizenship status, as well as sexual identity and orientation. And despite a lot of improvements that have occurred over time in different populations, many disparities are still persistent, and in some cases it has even widened. And so when you look at healthcare disparities, what are the results of this? We know that the death rates for African Americans generally is higher than their white counterparts, especially in terms of heart diseases, stroke, cancer, asthma, influenza, pneumonia, diabetes, and HIV/AIDS. And we also know that minority groups are groups of people who are treated unjustly or discriminated, and that statement was back in 1945 and oftentimes still rings through today. And according to the Robert Wood Johnson Foundation, across the healthcare services or health outcomes, they often depend on who you are, your race or your ethnicity. And so racial minorities continue to receive lower quality of care when compared to their white counterparts. And as well, when looking at the U.S. Department of Health Human Resources Office of Minority, the life expectancy at birth for Black males is about 4 years shorter than their white counterparts. And this is really important to think about because health disparities affect the cost of care in this country. So it's looking at $93 billion in excess Medicare costs and $42 billion in loss of productivity every single year. It's important to put this all in context because when we think about this, by 2020, it is projected that people of color will actually account for about 52% of the U.S. population. Shamira, any other thoughts?
Yes, so I'm sure by now you all know that I love to take things and put them into context. And so I just want to craft a story to really think through how we get to this position of health disparities when we're talking about African American communities. So we think about Jean, who is a Black woman who lives in a low-income neighborhood, one of those historically red-line neighborhoods that we talked about in the South, because that's all that she can afford. And so down the street from Jean's house, there's a landfill. And that means that she is exposed to pollutants, whether that be the air, her soil, and her water. And when you take that and you couple it with the things like her not having a grocery store within 10 miles, her not having a clinic where she can go and seek regular, reliable care, and her not having any sidewalks for her to be able to get out and find movement for herself, she is now at higher risk for the things that we see here, like heart disease, stroke, cancer, asthma, and so on, right? But Jean is not inherently at greater risk just because she's Black. She is at greater risk because of the structures in place that have disadvantaged her as a result of her Blackness. And that's why when we're having this conversation about healthcare disparities, you know, some people even push it as far to say that race is not a health risk factor. Racism is. Because the thing that we cannot change, or the thing that Jean cannot change, her Blackness, that is not the direct cause of these disparities that we're seeing here. It's the structures, the systems, how she's been treated, the choices and the disadvantages she's had across her experience, across her lifespan, that really contribute to that greater risk.
Thank you, Shamira. So let's move forward and really explain that in this scenario that we have here, because I think that ties in into this. So you've got two people here. You have Ben, who's 58 years old, and you have Joe, who's 58. They both live in Philadelphia, but again, when you think about Jean, now Ben lives in Nicetown, one of the most violent parts of Philadelphia, whereas Joe lives here in the nicer parts of Philadelphia. Now, in terms of education, they're really the same. They both have no college education. However, when COVID hit, the outcomes were drastically different between the two. Here, Ben dies from coronavirus, and Joe actually survives. So if you look closer into the different demographics, they're both male. One is African American, the other one's Caucasian. If you look at their comorbidities, it's very similar. If you look at their occupations, they're also very similar. Location, they're both in Philadelphia, but just different neighborhoods. And if you look at the income level, there's also a disparity there. And Ben has no insurance, whereas Joe has insurance. So when you look at these two people, you know that there is a gap here, and it's more than just the neighborhood, it's more than just insurance. So Shamira, I'd like you to put a few more thoughts into this one.
Yes, so you make really great points there. We do see some gaps or some differences when it comes to income, when it comes to the neighborhood, and when it comes to their health insurance. But as you quoted in the previous slide, even if all of those things were the same, there's still a potential that these two people, Ben and Joe, would receive different levels of care. So that's everything being the same, there's still the potential for them to receive different levels of care. And I know that in our next slide, you are going to walk us through how studies show this may be the case.
That is correct. So let's move forward into the next few slides. So let's take a look at health disparities and how it contributes to decrease in life expectancy. Let's focus on the left-hand side of the slide where you have the life expectancy by race in the United States. Now this covers over 40 years, where you can see the green lines there for the Caucasian race and all other races. They're actually very similar and higher, but if you look at the African American bar here in blue, you can see that although the life expectancy is increasing, there is still a gap between the two. Now let's move into the right-hand side of your slide here. In terms of the advantage, the Black advantage in diseases, There is an advantage in chronic liver disease and Alzheimer's, and chronic lower lung disease, in injuries and suicide. But the biggest killers in this country, which is heart disease, cancer, diabetes, and in certain cases homicide and perinatal conditions, there is still a huge disadvantage, that is. And then if you look at the disparities amongst patients, we do know that although there has been some improvement over the years, there is still a difference between African Americans living with or dying from many of these conditions that are found in white Americans at older age. So these differences may be due to economic as well as social conditions that are common in African Americans and white people. So when we think about our African American adults, they're more likely to report that they really can't see a doctor because of cost. Now let's move on to the different diseases that are common in this country, starting with high blood pressure and then diabetes and stroke. If you look at the differences between the two, in the different age group, you will see that at any age group here, African Americans have higher incidences of diseases than their white counterparts across the board in high blood pressure and diabetes as well as stroke. If you look at the right-hand side where there's the death per 100,000 people, you will also see that the death rate is higher at any age group here across the board. And Shamir, do you have any other thoughts on this slide?
I think that it is also very important to be mindful of how we frame narratives as we move forward. And so looking at this, African Americans are more likely to die at early ages from all causes. How often have we heard this? How often have we seen this in our studies? How often have we seen this in our textbooks? How often have we seen this in our different guidelines and recommendations? So we're inundated with that message over and over, and whether we realize it or not, it can shift our thoughts and our beliefs in the way that we deliver care. Now, I'll give you an example. Say you have plans to go outside, you want to be outside, enjoy some nice sunshine. And then you turn on the news and all you hear is about this rainstorm that's coming. It's like, it's going to rain, there's going to be so much rain, it's going to rain all weekend. And so in your mind, you may start to shift your plans. And instead of going outside, you sit inside. Why is that? It's because you know you can't change the weather. And I think in a similar way, when we hear this message over and over again about blacks being at higher risk or more likely to die at early ages from all causes, that kind of settles in. And why is that? Because that's something we can't change. We can't change the race. And if we think that someone is experiencing disease based on something they can't change, there's a possibility that might impact the way and the type of care that we provide.
Thank you, Shamira, and that brings a very good point. And is it the race or is it the environment or a lot of other multiple reasons? Now, shifting into the data on heart failure, and we're going to talk about hypertension as well as diabetes, let me just provide a context of heart failure throughout the world. There's about 64 million people throughout the world that's affected by heart failure. The morbidity and mortality of this disease remains very high and comparable to some of the most common diseases like cancer, despite advances in the therapies that we have. And people with diabetes actually have 2.5 times greater chance of developing heart failure, especially when they have progressed on in diabetes. So overall, when we think about heart failure, it does represent a substantial global burden, and we do have a significant unmet need here in terms of controlling morbidity as well as mortality in this disease. So I know that this is a very busy slide, but I want to kind of bring your attention to the top portion here. The combined prevalence of diagnosed and undiagnosed diabetes is about 14.3% overall. So if you look at that top line where the blue arrow is, so it's 14.3% overall. But if you come down just a little bit to the next blue arrow there, in the African American population, that almost doubles to 21.8%. And below that, you can see all the different races as well. And over a lifetime, an African American men develop type 2 diabetes more frequently, at least 1.5 times more often than their white men counterparts. And for African American women, they develop more than 2 times more likely to have diabetes than their white women counterparts. So when you think about the whole context, there's really 1 in 3, or about 36% chance that African Americans will develop diabetes and who are not diagnosed. And then we know that there are certain risk factors here that is associated with diabetes, and all of these things actually impact diabetes. So let me show you, and I know this is a very busy slide, but just bear with me. If we start with obesity here and we go counterclockwise, we know that obesity can impact the risk of heart failure as well as advancing age, which we can't do anything about. Chronic kidney disease is also more common in patients with heart failure, and if you look at coronary artery disease, they do impact the development of heart failure as well. When you think about the very common dyslipidemia, that does increase the risk of heart failure, and hypertension also makes an impact there. So all in all of these diseases can actually increase by 5-fold the risk of women to have heart failure, and about twice the risk in men as well. And we also know that there's a 33% increase of hospitalization for heart failure when they do develop this, if they have diabetes. Just keep in mind as well that African Americans, at least about the age of 18 to 49, are 2 times more likely to die from heart disease than their white counterparts. Okay, moving on to the next slide here. This is a study from the Southern Community Cohort where they enrolled about 27,000 patients to take a look at the contributions of at least 7 modifiable risk factors to the incidence of heart failure risk. So you can see here on the left-hand side, you have the black men and the black women. On the right-hand side, the white men and white women counterparts here. And you will notice that hypertension and diabetes, the top ones here that you see, were related to the greatest risk for heart failure, and the only statistically modifiable risk factor for the black participants. Now, looking at NT-proBNP, we also know, and I know that this slide is very busy, but the main message here is that African Americans tend to have lower levels of NT-proBNP, and just to kind of provide a context on that, NT-proBNP is a measurement that we use in terms of assessing heart failure severity and acuteness as well. So African Americans may have lower levels of NT-proBNP than the white counterparts. However, the mortality for all causes as well as cardiovascular mortality is the same across both groups. And then when we look at the slide right here, you can see that hospitalization for heart failure is actually highest among African Americans. So on the left-hand side, you can see the rates of hospitalization by race. And then on the right-hand side here is the heart failure hospitalization by sex and race. So it doesn't matter, both male and female African Americans have the highest rates, and it's actually the highest in African American female. So something worth thinking about. So black individuals that we know is more than 2 times higher rates of hospitalization in the U.S. compared to the white counterparts here. And then moving on to the next slide that we have here is the incidence and prevalence of heart failure. It's actually very high in the African American population. On the left-hand side here is the African American male and female, and you can see that it's very high compared to the white male and female counterparts here. And if you're looking at, and I know this is a little bit hard to see because the colors are all the same, but let's start with the first column here. Black male here, and then you have the white male, and then the black female compared with the white female. And you can see that when they start off at year 5, Many people are on stage 0, but when you look at year 30, you can see the difference there. So there's less people on stage 0, and then you can see a wider kind of like population of stage A into stage B, and then moving on to like stage C or D. So if you look across the board there, you actually see the disparities and the incidence of heart failure. It's actually very prominent, starting at a very young age, looking at this cardiac study, and then in which there's 26 out of 27 incidents of heart failure cases that occurred in individuals who are like less than 50 years old. Now moving into this slide, we know that patients here, if you look at the primary care ICU care here by cardiologists for Caucasians, you will see that a lot of the Caucasians here are seen by a cardiologist, and that's on the left-hand side of your slide. But on the right-hand side of your slide, you will see that, if a patient is seen by a cardiologist, they actually have better outcomes. So there's a disparity there. And then first hospitalization, if you look at this age-adjusted data that we have here, and you have the different color codes for the white males, the black males, the white females, and the black females, and you will see here across the board that there's disparities there. And then this one is on the SOLVE trial. In the SOLVE trial, we have mortality rates due to heart failure as higher among African Americans, and you'll see that it's about 2 to about 2.5 times higher across the board between men and women of African American descent. And subsequently, if you look at hospitalization rates there, it's also pretty high. Now moving into the causative factors, there are some genetic differences that we see that you see on the left-hand side of the slide here. And these are the variety of mediators that they actually have identified as risk factors in the development of CVD. Now this really impacts pretty much the initiation as well as progression of atherosclerosis care, their myocardial remodeling, their insulin resistance, the development of obesity in these patients, the development of hypertensive end organ damage, and as well as responses to drugs. And we know that these mediators can affect the African American population. And then moving into the data here, you can see the etiology of heart failure in African Americans, but across all etiologies here, it is higher in the African American population than the non-African American population counterparts. And on the right-hand side, you can see as well the cumulative incidence of hypertension here, much higher on the black male and female population than their white counterparts. And so moving into the risk factors that contribute to the pathophysiology of hypertension, shifting now to hypertension as a risk factor here, there are some genetic polymorphisms that we have to think about, as well as differences in the gut microbiota. And we know that this is actively being studied in different trials right now. But there's also comorbidities that we have to consider in terms of obesity and as well as the higher risk of CKD. Other factors also contribute, like psychosocial factors, the stressors that they may have, the low socioeconomic status, as well as poor access to health. And of course, the environment is a big player here in terms of unhealthy dietary habits as well as being sedentary. And then in this particular slide, and I'm not going to talk about every single trial, but you can see the span here from 1970 all the way to 2020. So this is a span of about 5 years, and these are hypertension trials across the board. And you can see that there's many trials that have been done in the last 50 years. However, identification of optimal combination therapy for African Americans with high blood pressure, which is really important, it still actually remains unanswered to this day. And Shamira, I'd like your thoughts on this section, please.
Of course, Chris, just as you said, while there have been these trials and that we've come a long way, there are still quite a few unanswered questions. And as we look at where research will trend moving forward, I think it's important to just start by offering a definition of race. So if we're looking at representation for African Americans, what does that actually mean? What is race? And race is a social construct, right? So it's typically used to categorize people based on their observable physical features. So that can be things like skin color or hair type or eye color. And it also might include shared experiences of culture, language, history, religion. And so there are so many factors that can play into race, and there's really no clear-cut definition that we use to classify someone based on race. And when we think about what it's not, it is not a biological construct. What does that mean? It means that we can't solely rely on race, because it's not so clear-cut, to define things like genetic traits or biological differences. And as we move to more personalized approaches, you might see more focus on geographic ancestry there. And an example of that would be, instead of saying something like diseases like sickle cell are more common in Black communities, you might hear someone say diseases like sickle cell are more common in those of sub-Saharan African descent, right? And so as we move forward and look at how things are shifting, it's likely that there will be more emphasis on genetics and biology, more emphasis on the experience of racism, as well as looking at how the social determinants of health are at play when describing and when evaluating risk factors for disease.
Thank you, Shamira. That really plays into how complex this is as America moves into a more multiracial community. Now, let's shift gears and talk about chronic kidney disease here and diabetes. In the United States, there's about 37 million people with CKD, and 9 out of 10 of these people actually do not know that they have CKD. If you look at the major contributors of CKD, diabetes, our area of practice, about 54% is actually the main cause of people developing CKD. But let's not also forget hypertension and other causes of CKD, because that plays a huge part in the comorbidities that develop over time. And if you look at the different stages of CKD here, and as you know, if you practice in diabetes long enough, that we actually see a lot of patients with CKD at an earlier stage versus the later stage. And the reason being is that they do remain in that earlier stage for quite a while, and majority of these people will die from cardiovascular as well as non-cardiovascular causes before they actually reach CKD4 and CKD5. Now, looking at the interrelationship of socioeconomic deprivation and CKD, and I think this really plays a huge part in different communities, including the community where I work in San Diego, California, because really the care that is given to CKD has a lot to do with residential segregation, to discrimination, as well as factors of being uninsured or underinsured. All of these things can lead to the development of, as well as progression of chronic kidney disease, as well as premature death because of end-stage renal. And I have seen this time and time again. And that's the reason why the burden of CKD is huge in this country, because really there's a huge disparity in the care of these patients, because this is chronic care that we're seeing here. And then if we look at CKD in the African American population, we also, have a lot of data on this one. Like, for example, African Americans are twice more likely to be diagnosed with diabetes. Therefore, they're more likely to develop chronic kidney disease as well, and that is 3 times higher risk. So it is more common in non-Hispanic Black adults, for example, and there's an excess burden of CKD in African Americans that can result in really high prevalence of comorbidities such as hypertension and diabetes. And Shamira had mentioned about sickle cell trait in African Americans. CKD is higher in this population as well. And there's also a high likelihood of progression from CKD to end-stage renal in African Americans than their white counterparts. And in the pooled analysis, looking at the ERIC trials, the cardiovascular health study, as well as the Framingham Health Study, the risk factor that is adjusted hazard ratio for mortality is actually higher in African Americans than their counterparts. And Shamira, I think you had some points that you wanted to say, I think in the last couple of slides here that I missed.
No worries. You have covered this beautifully, Chris. We can keep moving along.
Thank you so much. Okay. When you think about patients receiving optimal care, now shifting into hypertension here, only about 1/3 of patients with high blood pressure actually get the appropriate treatment, and that's nearly 1/3 of the aged African Americans. If you look at overall the potential eligibility of patients that can receive care, and in this case it's hydralazine, only about 25% of those who are eligible to receive the care are actually receiving it. Any thoughts on that one before I move into this slide?
Yes, so I will add, that reminds me, going back to our example of Ben and Joe from Philadelphia, and really showing how things like provider bias can impact care, where someone like Ben, the Black man from Nicetown, Philadelphia, might not receive the same level of care based on treatment guidelines as someone like Joe. And what do we do about that? How do you assess on your own if provider bias is playing a role in the type of care that you provide? I want to say it does not have to be a huge undertaking. I know a lot of us are short on time and the demand is high and we don't always have all of the resources, but there are small things you can do just to assess if this is something that's coming up in your practice or in your program. So one small thing, for example, would be picking a sample set of maybe 10 or 20 people that you're seeing from diverse backgrounds, and just take a look at those charts to see if there are any differences when it comes to treatment plan. So do you notice any disparity in the medications prescribed? Do you notice any disparities in the referrals or the screenings? And just making note of that, because that awareness is key to really building steps to move forward and bridging that gap.
Thank you, Shamira. So moving into the different trials here, and I know there's a lot of trials here, but just to kind of point out that African Americans are still underrepresented in different clinical trials, but I want to also put that in context depending on if the trials are global trials or they're trials done in the United States, because we do know that about 14% of people in the United States are of African American descent versus globally that may be around 2 to 3%. And so although there is a lot of improvement in the different trials, especially as in the later trials of the last decade, we still do need to keep this in mind and make sure that we include all races, especially African Americans in the United States, in the different trials that we have. And any thoughts on that one before I move to this slide here, Shamira?
I will add that even if you are not the one conducting the trial, you can still keep health equity in mind there. And the easiest way to do that is by simply asking questions. As you're reviewing these different studies, ask yourself, who's conducting the research, who's included, and more importantly, who is being excluded here. And answering those questions for yourself might change the way that you translate the information from the study into your actual practice.
Very true. And this is the part where actually I need your thoughts on. I know that historically there's been a lot of mistrust in clinical research because we haven't done a very good job with like the history in terms of like the Tuskegee syphilis experiments or the North Carolina eugenics program. And so all of these things actually contribute to mistrust of not just clinical research, but healthcare in general. Any thoughts on this, Shamira?
Yes, I think a big thing here is really first and foremost going back to that awareness and knowing the things that took place. And I think in knowing the severity of some of those things, it allows us as providers to have more empathy and more understanding when we are treating people and working with people from African American communities. And for instance, and I know we're running up on time, but quickly, how many people have heard of North Carolina eugenics programs? You know, it's not something that I was ever taught in school. It's not information that's readily available to a lot of us. But a quick overview of this, it was a period from about 1930 to 1975 where there were forced sterilizations. And if someone, in North Carolina specifically, there was a eugenics board. And if they determined that someone was unfit, or the term they used was feeble-minded, if they were too feeble-minded to reproduce, then they would enact forced sterilization on that person. And towards the 1970s, you know, as this went on, it was found that this had a greater impact on Black women specifically. So Black women were 3 times more likely to be routed to forced sterilization than white women, and 12 times more likely to experience forced sterilization than white men. And it's things like that that we may not know about, but that have a significant impact on the trust that people have in our healthcare system. And the only way to start understanding and really empathizing with that is to understand the full impact of it.
Thank you, Shamira. So that kind of brings us into like what our role is in heart failure and as well as diabetes and patients with hypertension and putting it all together. So specifically here as an example is a heart failure. And I know that we can really impact this. I was talking to Shamira about this. This is I feel, is where we can impact the most as diabetes experts and education specialists in terms of really making sure that patients are put on the appropriate care, like guidelines-directed medical care, that they're on the right medications that they need to be on to reduce their risk factors and educating them on it and helping them achieve their goal to reduce hypertension, to improve their diabetes, improve dyslipidemia, slow down the progression of kidney disease as well as valvular disease. And I think we are posed in a very good position to actually teach our patients on lifestyle modification, to really take a deep dive into cultural associations of food as well, because I know that is very strong, and I know as a Filipino that is very strong in terms of educating our patients, and we're getting better at this on smoking cessation, alcohol intake, avoidance of illicit drugs, and as well as getting patients moving. Any additional thoughts on this section here, Shamira?
Yes, Chris, I remember when we were first discussing this slide and how you mentioned the lifestyle modification piece. That is really our bread and butter as diabetes care and education specialists, and I absolutely agree with you. And as we are going and really focusing on some of those behaviors that you're mentioning, remember the structural factors upstream that also impact behavior change. And so keeping those different factors in mind, really also focusing on how can we connect with local resources. If someone is having a hard time financially, do we have a resource on deck that we can refer them to for financial assistance? How about food? How about housing? Making those linkages is going to be really important to creating that sustainable change, as well as figuring out avenues for support as it's available. So whether we're thinking about community health workers, navigators, community groups, all to really create an environment to help foster the change that we want to promote.
Thank you, Shamira. And that brings us to this, right? And I think this is my other favorite slide here that we discussed, because there are strategies to reduce health disparities, and I think we have made huge strides in improving that, but there are still more that we can do. So there are four kind of like buckets here in genetics and genomics, in randomized controlled trials, in management strategies, as well as behavior modification. And I was really thinking about like diabetes being posed for precision medicine, because then we can fine tune what we see as the core defect of a patient's diabetes and really catering to what the issue is. And then when you think about randomized controlled trials, even if we don't participate in it, is advocating for more diversity in all of our different clinical trials. And in terms of management strategies, we can make an effort to be culturally more sensitive. And if we don't know enough, to really be humble enough as well to ask questions and get to know your patients. And then in terms of behavior modification, I know we've specialized in this for decades, and we know this, and we got this. Any other thoughts on this slide, Shamira, before we take it to our last slide?
Yes, so as you mentioned, there are so many different angles to approach health equity work. And another resource, if you're looking to incorporate health equity into your practice or into your program, the Department of Health and Human Services has the National Standard for Culturally and Linguistically Appropriate Services in Health and Healthcare. And that's really a guide or a framework to help promote health equity. So that's a really good resource to consider. But one simple framework that I tend to use in my practice is the understand, ask, assess, and then act. And what I mean by that, when I say understand, first we have to even get started. You can't address it without knowing what you don't know. And so thinking about how you can incorporate individual and group learning experiences to develop that shared understanding of structural racism and health equity. From there, now that you have that shared understanding, you can figure out what questions you want to ask. You can ask things like, does treatment recommendations or goals differ based on race for our program? You can ask things like, do the Black patients that come in to work with us, are they experiencing racism when they're interacting with our providers? And so once you have that question asked, you can then identify some metrics to help assess that. And then once you've assessed it and you've kind of looked at how that's operating within your own practice or within your own program, you can act. And that's where we set goals. And I know we love goal setting, but that's really how you look at it and say, okay, this is what's happening. How do we come together to set a goal around doing something different, whatever that question may be and whatever those outcomes look like.
Thank you, Shamira. And that brings us to our last slide here, because we know that to approach this very complex, multi-layered, issues with disparity, we really have to approach it from different standpoints, from the federal government to public health professionals to the community as well as us in healthcare. And we have to work together and in our different silos, because I know that most of you listening here really work and can impact the communities that you have. So I think my challenge to all of us really is to take a look at our diabetes patients and not just think about lowering just their A1C, but to really look at the larger picture of their risk for progression in their metabolic disease, but also the components of heart failure, their hypertension, and their progression to CKD, and to take a step back and be more culturally sensitive and determine what our patients need, especially if you are taking care of patients in the underserved communities, as well as just knowing our populations, and today, in this case, our African American population, and trying to figure out how we can partner just within our organizations and even with the communities that we have impact on to improve and close the gap on all of these disparities. And anything else? Last thoughts, Shamira?
Yes, last thoughts. So I will absolutely agree with you in that this requires a holistic approach because of those health disparities as it relates to diabetes, as it relates to chronic kidney disease, as it relates to cardiovascular disease. All of those factors mean that we do not have the luxury of operating in a silo. We have to be considerate of all of those other factors when it comes to our care. And because social determinants, health disparity, because it's a structural thing, the solution also has to be structural, meaning it has to hit on all these different components that we're looking at. But there is no worries. You are not responsible for hitting on all of these different things. You're just responsible for keeping it in mind and doing what you can. And so something to really think about is lead where you can. So if it's assessing how you're doing in your practice, assessing how you can offer different resources or learning experiences, partner where you can. So working with those community groups or those community organizations who are already doing the work, and then supporting where you can. So using your personal or your professional platform to support policy and advocate for groups who have been historically marginalized, and figuring out what your role is in all of that. You do not have to tackle it all, but when you sit and take a look at it, there's definitely a piece that you play.
Thank you, Shamira. So this is the end and conclusion of our presentation. Thank you for your attention.
Great. Thank you so much for this presentation. We don't have any questions in, so we'll just move right to the end. But Chris and Shamira, I want to thank you so much for presenting and sharing your knowledge with us today. And thank you all for attending today's webinar. This webinar was recorded and it will be posted on our website next week, and it will only be available for 90 days, so make sure you check it out and share with your colleagues as well. And you can go ahead and save the date for our next webinar in the series on November 10th. So registration for that will be open soon. Thank you all. This concludes